Lactation Education Resources here. I am Angela Love-Zaranka, Program Director, and I have my esteemed colleague here, Sekeita.
Hello, everyone. I am Sekeita Lewis-Johnson, the Accredited Provider Program Director here at LER. Welcome and thank you for joining us today.
It's really good to see so many people here. We are going to talk about exam prep, how you've got this. Right? So just a little bit of an overview of what we're going to talk about today is, first we're going to give you a little introduction. Then we're going to talk about medications. We're going to talk about extended breastfeeding, which is beyond those first few weeks, physiology, milk supply, research, and sort of like the quick information you need to have about each one of these. Then we're going to ask you some questions. And in the questions, we're going to give you a chance to respond. And then we're going to show you the correct answer and then, talk a little bit about it if need be. And then finally, we're going to go over the exam survival guide. So you are welcome to ask questions, but you may want to wait until that section comes up. So if you would like to ask us questions or if you'd like to comment, take a look at the GoToWebinar platform. You can see where this blue arrow is. This points to the question box. It's also a comment box. So if you'd like to, for example, test it out and let us know where in the world you are participating today, we love to see all the different locations where you are located. And if you are participating today on a mobile device, take a look at the green arrow. That's going to give you the it's going to point to that question mark on the bottom of the interface, and that is where you can comment or question. Now, or ask questions. Now, we have some folks helping us out today. Julie is here. Julie is part of our customer support team. She's one of our instructors, and she is phenomenal. She is also an IBCLC, and she has information that you need, and she's going to answer a few of the questions during the webinar today, but she's going to really flag a bunch and we're going to answer them at the end. So she has taken the exam recently as well. Jill is here on our tech team, and Jill, if you're having any sort of tech issues, please go ahead and type them into the questions box, and Jill will take care of them as soon as possible. Okay, a few ground rules here. Please don't take any pictures or record this information with a camera or a phone or any other equipment. We are recording it, and you're going to be able to review it as many times as you'd like. Now, a few of the questions, as I said, are going to be answered by Julie, and she is going to flag some of them. And Julie is pretty knowledgeable. Julie loves to go into the research, and so she's going to provide you with the information that you need and then support us when it comes to answering the questions. Now, this is scheduled for 90 minutes. It may go a little longer. Just want to kind of give you a general sense as to how much time we're going to spend here. So let's go ahead and get started with medications. Sekeita, this is you. Take it away.
I am ready. Thank you, Angela. So before I get started into medications, just know medications is a part of life. And even during lactation, you will have questions as a lactation consultant, mainly about safety issues, because that's the biggest thing when we talk about medications, is whether or not they are safe, right? So I'm going to go over some key points that you as a lactation consultant should keep in mind, should know as it relates to your scope of practice when we're talking about medications, medication safety, and educating on medications, all right? So it's important to remember, first and foremost, that the amount of drugs or the amount of, I should say medications, let me just keep it, the amount of medications that are excreted into milk and the safety of medication while breastfeeding or chest feeding, or even just providing human milk, depends on many factors. For starters, a medication can enter into the milk if it is circulating within the lactating person's plasma. So it's in their blood system, it's circulating. that is the only time that that medications will go ahead and really transfer into the milk. So when we're thinking about this, we tend to look at, as far as safety, we tend to look at the milk, or think about the milk to plasma ratio. And this is useful because it really is trying to evaluate the concentration of the medication that's in the plasma compared to the concentration of the medication that's in the milk, right? And so as we think about safety, I'm going to build up on some of those principles, right? So it is the ratio of the concentration of the drug in the milk. The milk to plasma ratio is the ratio of the concentration of the drug in the milk divided by the concentration of a lactating person's blood. You won't need to know that. You will just need to know that hopefully you will just need to know that it is useful when we're thinking about it. We're thinking about whether it's safe. We're thinking about the relative infant dose. And this is an important clinical parameter because it's usually expressed as a percentage of the maternal or lactating person's dose. So we've already talked about, in the bloodstream getting into the milk. Now we're talking about what is the percentage of the medication that's going to be in the infant's dose, as opposed to what the actual dose of the medication that's given to the lactating parent. So according to HELS, medication in mother's milk, medications with a relative infant dose of less than 10% are considered relatively safe for a full-term infant. And I want to really stress that point. When we're talking about the relative infant dose and we're talking about the 10%, we are talking about full-term infants only, all right? So a relative infant dose greater than 10% for a full-term infant should be a cause for caution and a little bit of further assessment of the situation, okay? All right, now we're gonna move to the colostrum phase. Remember that during the colostrum phase, medications can enter into the milk easily. And why is that? It's due because there are large gaps between the alveolar cells. However, the total dose transferred to the infant is low. And why is that? Because infants are taking only limited milk volumes during the colostrum phase. So remember that point, that during the colostrum phase, it's easier for milk to transfer into medications, keep saying milk, medications to transfer into milk because of those large gaps between the alveolar cells, all right? However, again, the dose transferred is going to be low because infants are they're not taking large volumes at that time during the colostrum phase. And I just wanted to repeat that to make sure that that was clear, all right? So additional key points to remember. So the half-life of the medication. The half-life of the medication is a measure of how long it takes for that amount of the drug to decrease by half. So 50%. So how long does it take? Does it take 3 hours for the drug to decrease by half? Does it take 6 hours? Does it take a full day for it to decrease? So that would be a long half hour, right? It's usually expressed in hours, and just know that medications with shorter half-lives are ideal, all right? Another key point to remember is that most medications do enter the milk. However, they enter the milk at clinically insignificant levels, all right? However, once the medication does enter the milk, we start to think about what is the oral bioavailability of the medication to the infant, because that becomes important. And so what is that? Oral bioavailability refers to the ability of the drug to reach the infant circulation after it is ingested, okay? And that is after it is ingested through milk, right? Drugs with low oral bioavailability are generally poorly absorbed in the infant's GI tract, okay? They are usually destroyed in the gut or taken up in the liver prior to it even entering the infant's circulatory system. So remember that. We're looking at literally low oral bioavailability is a good thing because they're poorly absorbed, all right? from a practical standpoint, you want to be able to make sure that you are looking at medications from their lactation safety profile. And that is, that's key. That's everything we talk about. I alluded to that when I first started talking. So when we're thinking about that, we look at lactation risk categories. And it's a great start, but you always have to really take a deeper dive sometimes, because sometimes there's different set of circumstances. So remember, I said that relative infant dose parameter, right? That is a different set of circumstances for a preterm infant. So you have to use more caution with premature infants and neonates who maybe have some other underlying conditions going on, all right? Other safety considerations when we're thinking about medications include really being cautious if a person is taking high vitamin doses, also avoiding high doses of sedatives, opioids, radioactive agents, chemotherapy, and high doses of iodine. I'm going to go back to the high doses of sedatives because when I talk about sedatives, some of the medications that are used for pain can sometimes be thought of as sedative medications. And I'm thinking about situations that are for a higher acuity situation, such as someone who is potentially, and this is just me just telling you about how the synergy effect of when you combine 2 sedatives as opposed to 1. So you want to think about that. When we're saying high dose of sedatives, it may not be it's just a dose of 1. It could be this person is on a running dose of fentanyl, which is a narcotic. They could be on fentanyl, and then they could be on hydrocodone for some reason. Those are 2 medications that like together are going to cause a little bit more sedation in the infant, a little more sleepiness. So when we say high doses of sedatives, that's what I'm referring to. Is thinking about holistically in what cases would that involve. The good thing about the test is that you will be given questions, and you won't have to think about this from really your own clinical practice, but you do need to think about this from a prudent and safety practice of what does it mean to have high doses of sedatives, okay? And how does that impact whether or not this medication is safe? All right, so let's revamp. Drugs may transfer into the milk if, right? Let's see. Remember that drugs transfer the milk if they have a high concentration in the maternal plasma. I said that. Also, medications with smaller or small molecular weights can also pass into the milk more easily through the small pores, okay? Because when there's a small molecular weight, that means that it's very, very small. It can easily pass. When we're talking about large molecular weights, so there's a difference. Hale defines small molecular weights as molecular weights less than 500 Daltons. Now, I'm going to say this. In the current textbook, you may find a contradiction of that because on page 7, which is a different page than what I just quoted, the same book, on page 15, he states less than 200 Daltons. So just keep that in mind. When you see a question, you want to make sure, that number 500, less than 500, less than 200, keep that in the back of your mind. I have no idea why there is a difference in the textbook, but there's that. We do know that there can be varying differences in lots of textbooks as it relates to parameters and labs and all of those things. But anyways, I just wanted to point that out. All right. Protein binding is another factor that determines how easy a medication can enter into the milk compartment. All right. Most medications that circulate in the blood are bound to protein. That protein is usually plasma albumin. Remember, we said plasma, so it's bound to the plasma albumin as well as some other proteins, right? If a medication has a high affinity to bind to proteins, so it's stuck to the protein, and this is how I like to teach it. It is stuck there, meaning if it has a high affinity, it cannot enter into milk easily. So the higher percentage of binding, higher percentage that it's stuck, think about it like that, the less likely the drug is to enter into human milk. So a safer choice would be to choose medications that have high protein binding in order to reduce the infant's exposure to medications. And so key to remember some of these key points because they are valid test questions, all right? Another point to remember is that any medication that can pass the brain into the brain barrier, pass into the brain, can pass into milk easily. I'm going to go out on a limb and say this is a teaching point when I'm teaching. We know sometimes when we have to teach and educate, and this won't be on your test, but I'm just going to tell you how I teach when I'm teaching about this particular drug. Particular drug, namely, is marijuana. We know that marijuana passes into the brain easily, right? And so how easy it passes into milk, not really. There's mixed studies on half-lives depending on the dose and all of those things. But you also want to remember, if anything that can pass into the brain easily, it may pass into the milk easily. And so when we're talking about the brain, even with those sedatives, anything that can impact a person being, the brain being that it's gonna like pass into it for whatever reason, you want to really think about the evidence. What does the evidence say? You want to go back to your resources. You want to make sure that you are given accurate information as it relates to the best available data out there. And I use that because we don't have a lot of great evidence about it, and we have some evidence about it, but it's not exhaustive, right? So when we're thinking about the brain barrier and we're thinking about anything that can pass the brain barrier easily, it can pass into milk easily. So in summary, you do want to choose medications, those with short half-lives, high protein binding, meaning it's hard to remove it from that protein, low oral bioavailability, and high molecular weights, okay? All right, moving on to antibiotics. Now, when you look at these antibiotics, you're going to look at, you see that on this slide, I have listed the lactation risk categories, and I listed the lactation risk categories from HAIL. I do know that there are other resources that don't list the categories exactly how HAIL lists the categories, but when you're thinking about this, you don't really need to remember, you don't need to memorize what the L category signifies. What you do need to have is a general idea about the application of the categories of medication. So it's highly unlikely that you're going to be tested on if this is a L1 versus a L4, right? But you might be asked a question about what is safe, what is not safe. So, and you also might be asked questions about what are some huge concerns with antibiotics, right? Well, in this case, when we're looking at the medication list, and I pulled these, I used two resources for this, the core curriculum, what is it? The Interdisciplinary Lactation Care Core Curriculum book, as well as HAIL, and that's where I pulled the L categories. But with any antibiotics, whether it's myself taking it or whether or not it's through the milk, there's going to be changes in our gut flora. There's going to be the potential for antibiotic resistance. There could be the potential for some GI upset. When we talk about gut flora, we're talking about upsetting that GI system. So when you think about antibiotics, you want to think about it like that. The other thing is, I know it's a lot of medications and it gets very hard to memorize and to know all of the medications. But what I want you to do is look at this list of antibiotics and look at what they all end in. They all end in IN, ampicillin, amoxicillin, cephalosporin, clindamycin, azithromycin, penicillin. You get the point, right? Those are their generic names, all right? So when you're looking at medications and you get stumped and you're like, oh, what is ciprofloxacin? What is that? Those are some key things that I generally help students to remember. Looking at the name of the medication can sometimes give you an idea of even what the question is asking, because you know, sometimes it's hard to remember every single medication, right? But I said all of that to say, as a general rule, antibiotics are compatible with providing human milk, right? When you look at ciprofloxacin and erythromycin, they are noted as L3s, and again, they have been associated with GI concerns. And I think I've talked about many of the other things, and so we will go on to antifungals next. Antifungal. Well, fungal infections such as yeast infections, vaginal yeast infections, thrush, or Candida albicans, or even topical fungal infections. These are all conditions in which antifungals will be used. And if you look at this list, we're looking at the most common medications is nystatin. Now, remember I just said that it is an IN, the antibiotics. This antifungal, nystatin, ends in an IN, so this is an exception to one of those rules. If you see that, because nystatin is one of those medications that is commonly used, particularly for infants who develop thrush or Candida albicans of the tongue, okay? So when we're thinking about that, you wanna think about, wow, okay, and then you think about fluconazole and clotrimazole. Usually antifungals usually end in OLE. So anyways, just want to make sure that I'm covering the spectrum and helping you to really think about, like, what is this? What are we talking about? What medication is this? Sometimes just looking at the names can be helpful to you. All right, now we're going to talk about pain medications, because I talked a little bit about that, about the brain-blood barrier and the synergistic effect of high opioids or high narcotics. I didn't say opioids. All right, but analgesics are simply just pain medications that's common after birth. And we know that it's common after birth because, you know, first of all, birth can be painful, and analgesics is usually given during birth for a lot of people, not all people. Some people do birth without pain medications, and then they do go on to recover without pain medications. However, we just want to be clear, though, that there are some medications that you do have to pay attention to, particularly, again, the combination medications where we think about pain medicines such as the combination of acetaminophen and codeine. Those are usually categorized as a Tylenol 3 or a Tylenol 4. That 3 or 4 is significant to how much codeine is actually inside of that combo medication, right? But when we think about this medication, you're looking at acetaminophen, which is an L1, and you're looking at codeine, which is an L3, okay? And there's the properties of the drug, or the pharmacokinetics of the drug, really determine how these drugs are classified. Pharmacokinetics, what I just talked about, is a lot of things like the oral viability, but it's the whole totality and picture of it, right? Now, when we look at Norco, which is another medication that's given for pain, it's also a combo medication. It's a combination of acetaminophen and hydrocodone, and that's an L1 and also an L3. So keep in mind that these medications require just a once over. We're not saying these are not contraindicated, but what is of concern is that they are not contraindicated. It is safe for people to take this medication as they are prescribed. When they become abused in a different way and used in a different way, that's when the safety parameters fall out the window. However, even when they are being used in the way that they are intended, you do want to make sure that the infant is being watched for sleepiness, for poor feeding or sedation, and even respiratory issues. And that's just making sure that, you know, we are properly educating and that we properly know what sometimes these medications, what can happen sometimes with these medications. All right, so let me make sure I covered everything when I'm talking about these medications. Thinking about aspirin, Hale and Hale's book, basically he warns against, he says, avoid higher doses of aspirin during lactation, especially when infants have a viral infection. All right, back in the day, they used to say that aspirin was associated with Reye syndrome, and there's been some research, but I will say exactly what was stated. He states that direct use of aspirin in infants and children has been associated with Rye syndrome. The use of 81 milligrams per day dose, or even a single dose of 325 milligrams in breastfeeding mothers, has not been linked to an increased risk in the syndrome in these infants. And so what he's saying is within the dosing parameters of the 81 milligrams or the 325 milligrams single dose, there is no association with Rye syndrome. Anything outside of that, it could lead to potential negative consequences. All right. Morphine is a potent pain medication, and that's classified as an L3, but it is potent, right? However, it's used in a C-section, in a spinal cavity for C-sections. It's used for sometimes post-surgical pain management, and it really appears to be safe for limited use. And so again, when we talked about high doses of sedatives, this is one of those things. This is for limited use. It is usually considered, though, morphine out of all of the medications is considered the best choice because it is poorly absorbed in the infants. Remember, we talked about bioavailability. So morphine is poorly absorbed in infants. Dilaudid is another potent pain medication that is presumed compatible. But again, you always want to note that compatibility of these medications exists only when they are being used as prescribed. All right, so we're going to go to anti-seizure medications or anticonvulsants. Anticonvulsants is the classification, but I put anti-seizure here just so you kind of can make sense of what we're talking about, right? Anti-seizure medications are medications that really just minimize the risk of having a seizure, all right? And you can see there are varying lactation risk categories. One of the most common anti-seizure medication that is used during the perinatal phase is, or even postpartum sometimes, is magnesium sulfate, right? Magnesium sulfate is really just a laxative, but it's used to treat preeclampsia and preterm contractions. And so there are still, to this day, hospitals that are telling people that magnesium sulfate is incompatible with breastfeeding, and that is a chest feeding. That is not true. However, like any other medication that, remember I talked about the blood-brain barrier, you want to look for infant concerns such as sleepiness, poor feeding, and irritability. So think about it like that. There is a medication that should be avoided, and that's the valproic acid. That is an L4, and the other name for that is Depakote. That is potentially hazardous. All right, antidepressants. These three antidepressants that are listed on this slide appear to be compatible with providing human milk. As we have heard, and if any of us that are in the field, there has been more amplification of postpartum mood disorders. They are common, and sometimes they do require medication management. And so these medications are in the drug class that are called selective serotonin reuptake inhibitors, and they are the most prescribed for depression. All right. HALE lists these medications as L2s, so it's probably compatible. And so they seem to be the preferred medication for anyone that is going through some postpartum depression. Or someone who already is depressed and may have been on this medication even prior to pregnancy. Infants should be monitored for, again, sleepiness, poor feeding, low muscle tone, and agitation. And sometimes, depending on if the parent was taking the medication prior to delivering, sometimes the infants may expose what they call neonatal withdrawal symptoms to certain SSRIs. And SSRIs is what I just said, the serotonin, the selective serotonin reuptake inhibitor. So that's also something that we can see. One of the things that you will have access to, so I hope you're not taking a whole bunch of notes, and I should have said this before, is that you will have access to the medications handout that you will have with you that you will be able to use. So don't worry about writing all these things down. The one thing I do want to make notice of, if you notice, when I keep talking about infant concerns, what am I talking about? I keep saying sleepiness, poor feeding, those sorts of things, low muscle tone. I've also talked about GI disturbance. And so thinking about it from that, you know, some of them are overlapping some of the concerns. I'll move on to antihypertensives, which are medications used to control high blood pressure. Sometimes people are hypertensive before even becoming pregnant, and then they continue the medication afterward. Sometimes people develop preeclampsia and then they develop hypertension along with that, and they go home on a very new medication. And what I sometimes in practice find is it's mostly the people where the medication is new for them, where they're like, oh, I have a new baby and I have a new diagnosis. I'm on this high blood pressure medication, right? Those are the times where we have to really be sensitive in how we teach and what we teach, in making sure that we are looking at the varying lactation risk categories. And I'm going to share myself. I had hypertension, and I remember saying I didn't want to be on this one medication. I wanted to be on a different medication. And I remember because I felt it was safer. It wasn't incompatible, but I was like, no, I want this one. And my doc, and you know, I love my physician, so this is no diss, because this is the type of physician I needed at the time. He says, Sekeita, you want to stroke out or you want to breastfeed? And you could do both with this medication, but if we put you on that medication, it's not right for you. And so even me, it was not within my scope of practice to be trying to dictate what hypertension medication I was on, but it was within me to know what the categories were and what the safety profiles were. So when you're looking at antihypertensive, you will see, again, I talked about what's in a name. You can look at nifedipine and nicardipine, labetalol. These are all different types of drug classes. I won't get into the different type of drug classes, whether or not it's a beta blocker or calcium channel blocker. You won't need to know any of that. What you need to know is that most medications, hypertensive medications, are safe, but we still need to, or compatible, but we need to be looking them up. And we also need to be looking at them from the infant's risk factor safety profile as well. But also we need to be monitoring whether or not the infant is sleepy, is lethargic, or having poor feeding. So that is, or pallor, or very pale, right? I did put asterisks on this slide because there are two medications that are considered diuretic medications. And if you will, I'll use a slang term for people call them water pills, right? Get rid of the water. It really flushes, it's designed to kind of flush out sodium and those things that could be a contributing factor of hypertension. So the reason why there's an asterisk next to those, hydrochlorothiazide and furosemide, is because you see there is an L category, is L2, L3, presumably they are compatible. However, there is a potential to reduce milk supply by depleting maternal blood volume. So you really want to kind of make sure that, for example, a person who's on long-term Lasix, or whether or not they're on oral Lasix versus IV Lasix, I talk all the time about the care that sets the IBCLC apart. If you are somebody that's going to be working in a hospital and you have someone, for example, that's lactating on an ICU, they could be very well, if they have like a brain, something going on in their brain, they could very well be on Lasix IV, which is, we can see an extreme decrease in the milk supply and milk volume for that. However, even in spite of that, even when the milk dries up, I tell people, keep staying on that pumping regimen, keep the care plan going, because the reason it's depleting is because there's some other physiological factors combined with the medication factors that's going on. And once we get that Lasix, once the Lasix is no longer needed, you will see the milk start to rebound. And so I'm just giving you some clinical pearls a little bit, mixed with a little bit of teaching, mixed with how you might be receiving test questions, because really it's applying questions to clinical practice. So, all right, let's see, vaccines, our favorites. All right, generally speaking, vaccines are safe for breast and chest feeding. I'm going to read exactly what Lawrence and Lawrence says, because there's always lots of debate that happens in the chat. So here goes. All right. So according to Lawrence and Lawrence, smallpox vaccination is inadvisable for the mother or of any infant younger than 1 year of age, nursing or not. It is the personal contact, not the breastfeeding, that causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. The vaccination is not routinely given and is rarely indicated. Okay. When we're talking about yellow fever, that's a different story. Yellow fever is a live virus. There are case reports of encephalitis, which is swelling of the brain, in breastfed infants whose mother received the vaccine. Infants greater than or equal to 9 months of age can be vaccinated themselves or travel to endemic areas, but there is an increased risk of encephalitis from the vaccine virus in infants 6 months of age or younger. Okay, so what does this mean? The recommendations are to avoid vaccinating breastfeeding mothers with infants less than 9 months old if we're talking about the yellow fever vaccine. All right. Now, I've talked about a lot of medications. If medication and pharmacology are not your strong suit, I highly recommend that you read and study chapter 5, which is the lactation pharmacology in the core curriculum for interdisciplinary lactation care, the 2nd edition. You got 30 days. And when I say read, I'm not saying like skim. I'm saying read to know, read it like a novel, because sometimes medications can trip, in pharmacology and the principles thereof can kind of trip some of us up when we're taking tests and when we're trying to apply it to clinical practice. So that is where most of this information came from. Really take some time, if it's not your strong suit, to really take a deep dive into chapter 5. I believe I'm going to turn it over to my colleague Angela, where she will just blow your mind with some more fascinating information. So there you go, Angela.
Thanks, Sekeita. Yeah, there's a couple of questions in the chat that we may want to bring up later as well. So, okay, good. So now we're moving beyond medications, and know that this is being recorded. And so if we talk about something or say something, sometimes people will put in the chat, wait, what did you say? Or can you go back? And so the person who's presenting can't go back at that moment, and know that you can listen to this later as many times as you need to. So what we're going to talk about now is breastfeeding beyond the 1st month. And if you have questions about this, we do have content in our lactation consultant training program. We have individual modules where you can learn more, as well as our exam review. So all of these topics, as well as the medications, are all included in other lessons that we have. But this is sort of like the shortened view, that high overview on all of this. So when counseling clients with older nursings, be mindful that the number of feeds and the time at the breast may fluctuate gradually. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and 3 to 4 months in that first year. Now, developmental milestones, whenever a baby is trying to achieve different things, they may increase night waking and nursing. It seems to be that these little ones are just too busy exploring their world to spend time at the breast. If they do, they may miss something. So therefore, they may wake up more at night in order to receive the caloric intake they intrinsically know they need. Latch and position technique is considerably more flexible after the first few months. Take a look at the picture, the baby on top. The baby is further away from the breast than when a newborn. So unless the parent is uncomfortable, there's really no reason to suggest changing that position or the latch. Breast and nipple pain are 2 challenges that some mothers face while lactating. This is one portion of a 13-page algorithm developed by the University of North Carolina in the United States for breast and nipple pain. It is a valuable resource, and it's a really good review for the exam on how to identify many of the causes of breast and nipple pain. So know that this document is part of the handout which you have, and that questions box that a few of you have discovered, take a look underneath it and you'll see where it says handouts. And so you can grab the handouts if you'd like in order to review this to determine what to do with breast and nipple pain. Now, mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin and heat, together with systemic reactions of fever and malaise. Prospective studies estimate that the incidence is somewhere between 3 and 20%, and that really depends on the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis and abscess, which needs treatment if it's not introduced promptly, if the treatment hasn't not been started earlier. Symptoms include a fever of 38.5 degrees centigrade, which is 101 Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen, and the breast area is red or hot or tender to the touch. And some parents will notice red blotches or streaks or bruising of the breast tissue. The treatment is rest, to continue to feed and or pump on the affected side, cold compresses to reduce edema, creative nursing positions, breast movement or breast gymnastics, support compliance if antibiotics are prescribed, and use analgesic or an anti-inflammatory for discomfort and any fever or swelling. Now, I intentionally chose this picture to help you to try to see the mastitis. It can be challenging to note overt inflammation or redness on someone with darker skin tones. And as far as the latest, meaning within the past 3 years, mastitis protocol, yes, that could be on the exam. Of course, we don't know what's on the exam, but it is something which could be on the exam. Now, for recurrent mastitis, it's usually Staphylococcus aureus, which Dr. Lawrence says in her book that is the common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was also found by other researchers in the milk of asymptomatic people. In the case of recurrent mastitis, the diagnosis can be made with a milk culture and an infant nasopharynx or oropharynx culture. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol on the mastitis spectrum, as I mentioned before. Now, a small percentage of breast infections can develop into an abscess. Kinley et al. Reported the incidence somewhere between 5 and 10%, whereas Amir reported about 3% of women with mastitis in her sample developed an abscess. One theory is that healthcare providers are more educated on the prevention of abscesses. Dr. Lawrence reports an increase in an abscess rate when antibiotic treatment is delayed beyond 24 hours. An abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast. And this picture demonstrates an obvious abscess. Occasionally, though, an abscess can occur in the absence of any systemic symptoms. So treatment includes for these small abscesses, for a small abscess, which is less than 3 centimeters, the first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotics, which are effective against the penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage, The incision heals from the inside out, usually within a week or two. A parent may continue to nurse on one or both breasts, depending on the location, associated pain, and the medication. So switching over to the return of fertility, a small percentage of women will resume menstruation as early as 6 to 12 weeks. Others may not menstruate whilst breastfeeding has, others may not have their period until breastfeeding has ceased totally. It's usually dependent on the overall breastfeeding patterns as well as the parent. No significant change in the composition of milk happens with the return of menses. Hormonal changes, though, may alter the taste of milk, which can prompt the baby to be a little fussy or refuse to nurse. Some mothers may feel that it temporarily lowers the milk production whenever they do have their period. And it may also impact a family's spacing plans, especially if they're relying upon the lactation amenorrhea method. Now, pregnancy while nursing can occur. It's important to explore the mother's feelings about continuing breastfeeding. Some parents will note nipple and/or breast discomfort, and they report that discomfort alerted them to the new pregnancy. Depending on the age and the nursing relationship, some nurslings may be reluctant to wean. Mature milk will change back to colostrum around 4 to 5 months in the pregnancy, which may change the taste and the quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There's no need to wean a nursing baby or child unless there is a true risk of preterm labor. There is limited data which shows an impact to the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it's important that the mother is mindful of their diet. Now, some older babies or toddlers may stop nursing during the pregnancy and then resume after the birth. Tandem nursing is the term to describe breastfeeding of 2 or more children who are not born at the same time or are of different ages. It occurs when a parent nurses through pregnancy, or if a previous child weaned during pregnancy, they may be interested in resuming. It's again helpful to explore the parent's feelings about the tandem nursing. As one of the pioneers in the lactation field once said, Shelley Marmette, it takes the patience of Job to tandem nurse. Now, if there is an issue with the infant's weight in the early days, you want to ensure that the newborn is given priority at the breast. Some mothers will dedicate one breast to the newborn and the other one to the toddler, and then switch the next day. Take a look at this picture and you'll see that the older nursling has her arm around her new brother. Granted, it may be so everyone can fit on mom's lap, but it could also be a sign of affection. Now, if a parent expresses a need to wean, it's again important to explore their reasons. Some families believe that weaning may increase a child's independence or help a child to sleep more at night, which may not be achieved through weaning. Gradual weaning usually works best for both the parent and the baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse a child's request to nurse. You want to eliminate a feeding about every 2 to 4 days and preferably not back-to-back feeds. Continue as both parent and child accommodate the new routine. The mother can hand express for comfort as needed. Changing up daily routines for the child so that there are alternatives to nursing and they are offered to the child as well as explored. Other foods and drinks just before regular nursing sessions can help. And breastfeed when asked is another suggestion, but do it for shorter periods of time. Okay, Sekeita, we're going to take a little pause here. And I just checked to see if there are any questions. However, I think that they have all been answered in the chat. So let's see. Mastitis, advise the patient to empty the breast or only express some milk for comfort. Remember, the breast is never empty, that it always has milk. So it's, again, it depends on, I think it depends more on comfort. And yes, Julie is responding to all the controversial questions. And I think it's important to, again, if you do receive the question on mastitis, it's important to read all of the information in the stem of the question as opposed to the stem of the question as opposed to making assumptions, right? All the information that you need is in the stem of the question. Someone mentioned where Ms. Johnson mentioned reading chapter 5. So that's going to be in the interdisciplinary practice for lactation consultants, for lactation care. Hold on a second. I have a stack of books here. And oh, that's the first edition. So this is the first edition of the core curriculum. It looks like this, but I'm pretty sure Sekeita was talking about the second edition, which is the latest one, which is this one here, right? Chapter 5.
Yes, it is. Thank you, Angela. I only find it fitting to give information that's the most updated. And so that's
Right.
the reference that I use, which is right here too, Angela. I have my little handy book, right? So yeah, I do see some of the comments, some very interesting comments. We will do our best to address those comments and those answers, but I want to just applaud Julie right now because Julie has been working out these questions, and thank you, Julie, for doing that. As I'm trying to read and catch up with a lot of the comments, it's been wonderful to see that Julie is already, she has us on lock. So there's that.
She does, yeah. And to the question, yes, the generic term is going to be on the exam. It's not going to be the trade name because the trade name can be different in different countries. So they're not going to list all the trade names.
And I do want to say this, when we are preparing this information for you all, we're preparing it not from the lens of this is going to be on the test. We're preparing you to be able to take an entry-level exam of the things you should know in practice, because that's how the exam is going to be set up, like a practice exam.
Mm-hmm.
It's really important to, and Angela's going to talk about some test strategies, but I do want to just make that clear. So we do this almost for every single test so that we are also up to date, and we're bringing you up to date information as we have it. And so thank you for, hanging in there with us. And any clarifying questions, we do have our textbooks. Anything that we misspeak, we will go back to our textbooks and look it up for you because they're sitting right next to us. So there you go.
That's true. And to your point, thanks, Sekeita, to your point about up to date, we have our exam review product, which is just solid. And if there's ever anything, and that's one thing about LER, is that we update our content on a regular basis. And we also review the student evaluations for all of our content. That is where, Sekeita, one of the many ways that Sekeita shines is we actually take a look at the data and we reflect upon it and say, is this something that we need to change in our content? We do it in our exam content as well as we do it in our all of the content on our website. So please do take a look and know that it's up to date. And for example, with our exam review product, that's one thing that Julie does is she'll take a look at it and say, oh, wait a minute, this has changed. Or I will take a look at it, or someone will take a look at it and say, oh, wait, that has changed. And so then the beauty of our content is that we can take a little snippet and record it or add a slide to it so that it is up to date. So indeed, our content is up to date and will help you to pass the exam. Okay, Sekeita. Now I'm going to jump into milk supply. And this picture is in your handout, and just a reminder of the neuroendocrine reflex arc to really remind us of this physiology, the physiological mechanism of lactation. Milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It's milk removal that enables milk secretion to continue. This is a slide you may have seen in our anatomy and physiology, as well as in our relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes such as retained placenta or lack of pituitary prolactin. A glandular cause might be surgical procedures such as a reduction mammoplasty or possibly insufficient mammary tissue. And post-glandular would be any cause for ineffective or infrequent milk removal. There are iatrogenic causes of lactation, failure, which are those which are impacted by policies and procedures in a hospital or by a healthcare provider, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be included as a post-glandular reason. So taking a little bit of a deep dive into post-glandular, it's the iatrogenic reasons for failure, lactation failure. It's a separation of the mother and the baby using a pacifier. And as mentioned in the previous slide, perceived insufficient milk by the staff or family, which leads to supplementation. Now, interventions which require supplementation of milk supply is not a milk supply which is not simultaneously supported through hand expression or pumping is something which can negatively impact breastfeeding in the milk supply. So consider this common supplementation scenario. A parent is told that they have to supplement their baby, and they may not feel, the parents then will take that in and say, oh my goodness, my baby has to supplement. They can feel that they have failed with breastfeeding already, at 24 hours of life even. And well-meaning health providers may not encourage the resumption of breastfeeding if the interventions are being effective. Common scenarios include a baby diagnosed with hyperbilirubinemia in the early days and supplementation with breast milk substitutes, which has begun, or let's say a 2-week-old baby who wasn't gaining effectively and begins to gain with supplementation. In both cases, the parents may be afraid to resume exclusive breast or chest feeding or human milk feeding, and healthcare providers may not have the time or capacity to create a care plan to help the baby to return and remove the need for supplementation. Now, finally, there are some cultural beliefs that can create a barrier to normal breastfeeding, such as the colostrum not being good enough or in enough of a quantity, or colostrum which is bad for the baby. So breast and chest anomalies, this would include surgical interruptions in the breast or chest area, breast biopsy, breast reduction, augmentation, or a chest tube as a preterm baby or a thoracotomy prior to mammary development. So another anomaly could be mammary hypoplasia, insufficient glandular tissue, mammary asymmetry, or an intra-mammary distance, which is the space between two breasts, as you can see in this middle slide here. Other impacts on milk supply could be chronic illness such as hyper or hypothyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness or birth-related complications include hemorrhage after birth, especially causing a large or sudden drop in the blood pressure and or requiring a blood transfusion. As a point of reference here, 500 milliliters of blood loss is normal. Hemorrhage may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan's syndrome is a severe hemorrhage and drop in pressure that may result in necrosis of the anterior pituitary. Hormonal issues include irregular menses, infertility, obesity-related issues, PCOS, which is polycystic ovarian syndrome, weight loss surgery, specifically gastric bypass surgery, can impact the amount of nutrient absorption that the parent has in order to sustain lactation. So other factors for delayed lactogenesis 2, which is greater than 72 hours, includes a premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health on the slide refers to an interesting study from Namsen Rivers, which describes 3 risk factors for delayed lactogenesis: higher BMI, increased maternal age, and larger infant birth weight. These are known correlates for a carbohydrate intolerance and systemic inflammation. And I also want to point out that another issue which could impact delayed lactogenesis 2 is a fat-phobic bias. and staff who are unaware of their bias and do not support families. Again, more factors include for the parent, hypertension, high levels of stress to the mother and fetus during birth. And so this one includes a cesarean birth, especially when it's urgent, a prolonged stage 2 of labor, and prolonged means greater than an hour, augmentation of labor with intravenous oxytocin, a forceps or vacuum delivery, and the timing of the first breast stimulation following delivery can impact it. The significant edema, as you can see on the slide, of the extremities, because the breast is included in this piece, and endocrine disturbances. So as I've gone through all of the information in this slide, you can see that there are complex interrelationships amongst these different factors which could impact lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiological response due to delayed or ineffective suckling, or a combination of factors, that has not yet been clearly identified. Early, frequent, and effective breastfeeding appears to be the most important factor in establishing normal lactation. Now, I would argue that skin to skin and milk expression in the first hours after birth are the key factor to counter any sort of possible risk factors that we've just reviewed. For those of you who work in a hospital setting, you can understand how that different policies and such may be enacted or may be in place, which can exacerbate any of these above conditions. Okay, now we're going to switch to the infant's role in milk production, because it does take two in order to build a good milk supply. So any issues for the infant which could affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal in order to initiate and maintain an adequate supply. Important factors include the gestational age, so premature infants, of course, and remember that those late preterm infants may not suckle well enough for adequate milk removal. That's why we call them the great pretenders. The infant's oral and facial anatomy could impact. Any tongue mobility restriction could impact not only maternal nipple discomfort, but also the ability to remove milk. Palatal issues, obviously, which include a partial or complete cleft of the hard or soft palate, but it also could include a high palate, a bubble palate, or a channel palate, amongst many other descriptors for a palate. And airway issues, which include laryngomalacia or tracheomalacia. Now, long-term, the issues on the previous slide can impact the initiation and calibration of a milk supply. The following can impact the maintenance of milk production, such as infant hypotonia or hypertonia, birth trauma pain, such as shoulder dystocia, or the use of forceps or vacuum, cardiac or respiratory issues, and long-term impact could include those infant facial anomalies like with the tongue or with the palate, as well as sensory integration issues. Now, solutions. I like to come with solutions as well. So if you're working with families, there are ways to get a milk supply off to a good start. And so during the hospital stay, we want to have frequent skin-to-skin contact. Frankly, you just can't overdo that. Frequent colostrum or milk removal, hand expression does seem to work best. Now, a quick note for parents who are pumping for their premature infant or they're having trouble extracting an appropriate amount, the utilization of the other senses can help with that milk ejection reflex. There was a really great study which noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos, as well as smelling their t-shirt or blanket from the day before. Providing parents with the appropriate anticipatory guidance about normal newborn circadian rhythms can help to build a good milk supply, knowing that those nighttime feedings are normal. Visuals of the newborn stomach and, informing parents about the nominal nutrition requirements in those early days can be helpful and encourage parents to continue to directly nurse. Realistic expectations about baby behavior. And if supplementation is necessary, providing alternative supplementation techniques if they are required. And of course, another good thing to get off to a good start with building a milk supply is to ask questions, is to follow up. Yes, ask questions. I was going to ask for questions after this section, but I think I'm going to keep going. But it's important to have an appropriate follow-up. In other words, sending a parent home and saying, oh, we'll see you in 2 weeks, or oh, the month of visit will be fine, or even after that early newborn period, you really do want to follow up with parents to make sure that they're getting all of the information that they need and appropriate follow-up. Okay, so now we're going to talk a little bit about research. And so when we're talking here about research, we want to remember a few key points. So the dependent variable is what the independent variable acted upon. For example, in a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable, and the type of pump is the independent variable. Now consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent is pumping. That could lower the amount that they're able to extract. Or time of day could also be a confounding variable. Many parents find that they extract more milk earlier in the day as opposed to later in the day and in the middle of the night. So just want to quickly review some of the most frequently used terms. So the standard deviation is a measure of how spread out the numbers are. 68% will fall in the first standard deviation, which you can see here in the green. 95% will fall into the first and second standard deviation. And 99.7% will fall into the first, second, and third standard deviation. Only a few are going to fall into the fourth standard deviation, which is the teeny tiny number on the tails of each one of the sides of this curve. Now, statistical significance is the level of certainty of the results of a study. If we want to be 99% confident of our results, then we set the significance level to 0.01. If we want to be 95% confident of our test results, we set the significance level at 0.05, which is most medical research. Now, there is bias, means that there could be, something which is influencing the research, and there are different types of bias. For example, let's say there is a piece of research that looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute of the pump. Now, you note that the university who supported the research is funded by a specific breast pump company. The researcher who receives funding from that pump company could be biased in their study design or in the interpretation of the results. And finally, informed consent. These are subjects which need to be, this informed consent are for subjects in the study who need to be told about their rights, equipment, medications used, procedures, confidentiality, and how to withdraw from a study at any time, as well as any rewards for participation. Okay, great. Now, we're going to jump into question time, where we're going to practice a little bit. And so I want to just pause here to see if there are any questions that we need to answer so everybody can hear it. Okay, the great questions here about which nerves are related to the breast in breast surgery. So T2 to T6. Yep. So T2 to T6 are the vertebrae. The 4th, 5th, 6th are the nerves. And the 4th intercostal nerve is the most important, which is great. Thanks, Julie. WHO standard. So the growth chart, use the WHO code chart. That's the one that you want to utilize. It is something which is the standard, I believe, in almost all countries around the world these days. That was launched many, many years ago, if not a decade or two. Okay, and the handout is up to date. The handout that you have is up to date. As I said, we review the content before the webinar to make sure that it's up to date. So even if the date on there is a previous date, it is the latest one. And I see, I'm checking now, and it does say 2024. That's just an Angela way of organizing all of the files that I have on my computer, is that I put the year first, but it doesn't mean that it's out of date. So it is spot on. It is ready to support you for this exam. Okay, great. Okay, I think we caught everything. Thanks so much, Julie and Sekeita and Wendy. Awesome sauce. We're great. All right, so Jill, here we go. We are going to, someone wants to know if we're going to discuss the new exam scoring. Is there new exam scoring? I just know of this how they IBLCE scores the exam. And yeah, why don't we pop that to the end and talk about it? So, and to the person who says that we don't give all the slides, you're right, we don't give all the slides. And the reason why is because, for example, if they have pictures on them, we try to limit the exposure of those pictures out there in the wilds of the interwebs. And the reason why, it has to do with permission. Several of those pictures are mine from my practice. Several of them are from LER, from examples of how to teach something. So just want to say that that's the reason why all of them are not here. And again, listen to us over and over again. You'll start to get sick of our voices, mine and Sekeita's voice. Okay. So now here's what we're going to do. So Jill, our amazing tech person, is going to be helping out here. And so what we're going to do is she's going to launch the poll. We're going to keep the question up for about anywhere from 45 to 60 seconds so you can respond. Please do respond. Let's have some fun here. Let's see how people do. And so let's go ahead, Jill, if you're ready, and let's launch that first poll. So the physical presentation which may contribute to low milk supply is significant infra-mammary fold, a breast cup size which is less than B, significant intra-mammary distance, and hypoplasia of the superior breast tissue. Okay, I read that out loud. Note to us, Jill, is I'll read first next time before you launch the question. So, but this is good. And the reason I read it out loud is for folks, for accessibility, but also not all of the words are in the question itself, just because the interface only provides us with a certain amount. Okay, it's been 45 seconds. Come on, y'all. Go ahead and answer. And let's see how you do. Another 5 seconds. You got this. Okay, go ahead and close it, Jill. Great. So the majority of you got this question right. The answer is C, significant intra-mammary distance. So that's the distance between both of the breasts, if these are two breasts right here. So the distance between them is the thing which can be the physical presentation which can contribute to low milk supply. Okay, great. The infra-mammary fold is not it. So if this is the breast, and we take a look at the breast on its side, that's what this is. From the top of the breast to the bottom of the breast, that's what this is. I should have brought my breast model with me. Many apologies. So that's what we're looking at. Okay, going to the next question, I'll read it first. A postglandular reason for insufficient milk production is the early introduction of hand expression, pacifier use, retained placenta, or a previous breast biopsy with the periareolar incision. Okay, go. What is a postglandular reason for insufficient milk production? The early introduction of hand expression, pacifier use, retained placenta, previous breast biopsy with a periareolar incision. I'm going to take a quick drink. Let's give you all, y'all are really grabbing this one. You're getting this one pretty well, which is nice. No one is falling for just a straight out wrong answer. I'll keep that in mind. The wrong answer is to be helpful to you so that you can cancel one of these selections out. So remember, this is a postglandular reason. Let's say another 5 seconds here. Okay, good. So the correct response is B, pacifier use. So it's a postglandular reason, a retained placenta, and the previous breast biopsy belonging to the other categories. And so this is a postglandular reason. And I know that retained placenta is a little tricky because you think post, you think after birth, but actually retained placenta is not part of the postglandular reason. So just want to let you know for why it's incorrect. Okay, and that retained placenta, just FYI, is known as a sophisticated distractor. And so if you missed that question, then just go study that one little part on the reasons for low milk supply. Okay, I'm going to start to read, and I will not pronounce one of these words correctly. Let's see if you figure it out. While reviewing your postpartum patient's chart, you see that they received Pitocin, which is synthetic oxytocin, and Methergin, with its I did it, Sekeita. Methylogonovine maleate. I should have practiced. After a vaginal delivery. You know this patient most likely, A, experienced a normal blood loss, B, experienced an excessive blood loss, C, had twins, or D, will not be able to breastfeed. Okay, so a postpartum patient, they received Pitocin and Methergin after a vaginal delivery. So you know this patient most likely will, and then experience a normal blood loss, experience excessive blood loss, gave birth to multiples, will not be able to breastfeed. So there are not too many sophisticated distractors here because y'all are really knocking this one out of the park. But go ahead, come on, give it a try. Answer the question. It's okay. 66% of you have voted so far. You see, I can see all this stuff here on the back end. So what do you think the response is? Well, since you all are just, doing so well on this one, I think we'll go ahead and close this in about, there we go. Thanks, Jill. Okay, so 89% of you got this right, which is experience an excessive blood loss. So remember that the first line medication, which is used in the management of excessive blood loss during the 3rd and 4th stages of labor, is Pitocin. But if bleeding does not decrease, a second medication is indicated. So providers may choose amongst several second-line medications, such as Methergin. So A is not correct because management of normal blood loss does not require 2 medications. C is not correct because the delivery of twins does not require 2 medications. And D is incorrect because excessive blood loss does not necessarily mean breastfeeding will be unsuccessful. Okay, most of you got it right. And I would be willing to bet that some of you who didn't get it right probably meant to click on the right answer, but you messed up. So anyway, all right, I'm going to go to the next question here. So here we have Lilo Lactation Consultant did a study in their hospital. Families were randomly placed into 2 groups. One group received an intervention and the other group received the standard postpartum care. What type of research is this? Is it A, quantitative, B, qualitative, C, historical, or D, epidemiological? Okay, so there are 2 groups, families randomly placed. One group received the intervention and the other group received the standard postpartum care. So what type of research is this? Is it quantitative, qualitative, historical, or epidemiological? Okay, great. Now this one, it's interesting because it's got a sophisticated distractor to it, which may make it a little challenging. And indeed, you're responding beautifully. And, it's something like, oh, which one is it? So. Come on, go ahead and pick one. There we go. Give you another 5 seconds. Okay, great. So the correct response is quantitative. So 60% of you got that correct, but 39% of you went to qualitative. And that's why those two with each other are sophisticated distractor. And so knowing what the difference is between quantitative and qualitative is really going to help here. So qualitative research explores real world context based on perceptions. it considers multiple perspectives. There's no attempt at causality, and its use of interviews and observation. That's qualitative research. Quantitative research is experimental research to discover causal or correlational relationship between variables, and it's based on data collection and analysis. So this one, the correct answer is quantitative. Okay, now we're going to go to the next question, and here we have Lilo Lactation Consultant, who is a busy person, and they did another study in their hospital where she surveyed parents about their satisfaction with breastfeeding and what type of problems they encountered. So, which type of research is this? Is it quantitative? Is it qualitative? Is it historical or epidemiological? Okay, here we go. Thanks, Jill. And so now we are trying to figure out what type of research is this? Is Lilo really going to do the same thing here and do the same type of research twice, which she may do, if that's something which is, if that works for them? Or is this something which is different? Is Lilo trying to catch different data in order to find solutions and answers to problems? Or not even problems. They could just be how they're functioning, how the hospital is functioning. And especially with breastfeeding and what sort of problems they encountered. Okay, well, we'll give you another 5 seconds because a lot of you voted and most of you got this right. So thanks, Jill. So the answer is B, qualitative. And so yes, that's the nice thing about it. Most of you got this correctly, that it is qualitative. And again, I am bringing up the definitions of qualitative versus quantitative. So you'll notice in this example, it is exploring real world contexts, and it is not trying to show causality, right? It's not trying to show causality. It just wants to get the information about what sort of problems they encountered. Okay, great. So next question. Here we go. Iron levels are low in breast milk. What recommendation should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation is needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet, which will increase the amount of iron in the breast milk. Okay, good. Now go ahead and start this. So iron levels are low. What recommendation should they be given? Supplement with iron drops until the baby begins solid foods, which are fortified with iron. Breastfeed, you don't need to supplement. Breastfeed and supplement at 6 months with iron fortified foods. And increase the amount of iron in your diet so that you can increase the amount in your breast milk. So I'm giving you a little bit more time here, and the reason why, even though a bunch of you have voted, thank you so much, there's a reason why I have this, have some of these distractors in here. And I'll tell you the reason once you've finished voting. Give you another 5 seconds to respond. A lot of you are getting it right. Okay, great. Thanks, Jill. So the correct answer is C. Additional iron intake by the mother will not increase. So D is not right because the additional iron intake in the mother will not increase the iron levels in the breast milk, even if the mother is anemic. So iron supplements taken by the parent may produce constipation in the baby. So that's something to consider. Anemia in the nursing mother has been associated with a poor milk supply. So the correct response is C. Breastfeed and supplement at 6 months with iron fortified foods. And so remember, the iron levels are low in breast milk. So this is for someone who is, what would the normal baby do here? There's no other indication that the parent or the baby is low. So this is just what is the typical recommendation. And most of you got the correct response, but it was kind of all over the place. So if this is one where you missed it, then go ahead and study about iron levels in breast milk. Okay, now we're going to another thing in breast milk, which is vitamin D. So those two are low in breast milk. So what is the current recommendation? A, supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation is needed. C, breastfeed and spend about a half an hour outdoors daily. Or D, baby should be supplemented with 400 IUs of vitamin D daily. Okay, so vitamin D levels are low, so what should we do? Okay, so what should we do? You know, this one is sort of making me laugh on the inside about this, so this is great. Answers are a little all over the place. I would be curious. Remember I said before that maybe some people got it wrong, but they knew which one the right one answer. I don't know if you can like change your answer or not, or if you just, when you hit submit, you have to vote. So if anybody wants to comment on that, if you've got a minute, that would be great. I'm just curious, that's all. So 5 more seconds, about 80% of you have voted, which is great, yay. People have found the button in order to respond. Okay, great, thanks, Jill. So the response is D. Babies should be supplemented with vitamin D until they're about 2 years old or receive adequate amounts in their food or liquids that they are ingesting. So this is from the CDC, or I'm sorry, the WHO, the World Health Organization. And I'm going to quote directly from them. There appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets. And so this one is a little challenging because I am aware that there are some things out there which say, oh, put the baby in the sun for a half hour, but frankly, a day, but frankly, that doesn't take into account A, where in the world that person is located. Is it northern hemisphere? Is it southern hemisphere? And is it considered the summer or is it considered the winter in that hemisphere, or fall or spring or whatever it could be? And then, you know, supplement the baby with vitamin D until solids are started. So that one is a little bit of a sophisticated distractor, but indeed the current recommendation is to go ahead and supplement them with the 400 IUs of vitamin D daily. So, okay, great. Now, go into the next question. So this one, I want to keep the picture here for a minute. So I'm going to talk you through it a little bit. So think about how old this baby is. So the thing that you want to look at are, notice that sweet little smile, right? That appears to be a social smile, right? Parent is there getting the picture of the baby. Also notice that the baby can lift their head at about 45 degrees. And note that they can hold their head up for a few seconds, right? Who knows how long that baby has been there, but chances are they see their parent and they're like, ah, and they're able to visually search to locate that familiar face or sound. So we've got the auditory piece here. So is that it? Okay, so here are the choices. The choices are, is the baby A, 2 weeks old, B, 4 months old, C, 2 months old, or D, 8 months old? Okay, Jill, go ahead. So you saw that picture. I know the picture just went away, but think about it. Is that baby about 2 weeks old, 4 months old, 2 months old, or 8 months old? How old do you think that baby is? And I have to say that I know the answer because I know who this baby is. This baby is the child of a dear friend. And so take a look and see how old do you think that baby is. Okay, so none of you are getting the incorrect response. So yay, glad to see that no one's getting the incorrect one wrong, or the incorrect one, you're not choosing that one. Oh, but it is neck and neck. So there is a sophisticated distractor here. And go ahead, Jill, and close the survey. So that sort of question, so the correct response is B, 4 months of age. And here's the thing, is that, you know, it's not 2 weeks, everybody got that one right. It's not 8 months, it could be 8 months, but then that would be a little delayed, right? So and 2 months is a sophisticated distractor, And the answer is actually 4 months. So at 2 months, oh, I just did something very funny. I started talking about the wrong correct answer. So this baby is 2 months old, and the sophisticated distractor is 4 months old, because the reason why it's different, you see, even me, I'm looking at this picture and I'm finding this without checking my notes, right? So this baby is 2 months old because at 2 months, a baby can take their hands, place it against a hard surface, and lift their head, but only for a few seconds. A 4-month-old baby is going to be able to do more and to move more. Notice this baby's fists are closed. And so that's the reason where, they're not exploring, right? They still have this movement when they're trying to lift up and to look at the baby and to smile at the baby. Are the questions on the exam going to be this hard? No, they're not. Okay, so the reason why I'm doing this is just to sort of talk through what you're looking for when you're looking at a baby, and the information in the question is not going to be something as simple as how old is this baby, right? It's going to be something to the effect of, this baby is doing this and this and this, or you notice this baby in this specific setting. And so they're going to provide you with more context in the item, as opposed to saying, how old is this baby? Remember, the exam is for application and not sort of like gotcha things. Okay, next question. Which of the following viruses are most likely to be transmitted to the infant through breast milk from an infected parent? Is it A, hepatitis C, B, herpes simplex virus, C, varicella-zoster virus, or D, cytomegalovirus? So which one of the following is most likely to be transmitted to the infant through breast milk from an infected parent? Okay. Do consider there are vaccines out there for some. So taking a look and seeing which one it is. People are sort of answering different things. So I'm going to let this one sit for another minute or so. And someone is telling me you make the poll selection and hit submit. So you can change it until you hit the submit button. Okay, great. Thank you. Okay, good. So the correct response is D, cytomegalovirus. It is the transmission from parent to infant occurs in about 60 to 70% of dyads where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV, and there is debate about whether these infants should receive CMV positive breast milk. Whenever there is debate, that's probably not going to be on the exam. IBLCE doesn't like to take controversial things and put them on the exam and say which is the right one. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. And varicella-zoster virus which causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The only caveat is that the infant should be protected from direct contact with skin lesions. So the correct response on this one was D, cytomegalovirus. Okay, a few more questions here. Tyler's diet is vegan. What would you suggest to ensure adequate nutrition for Tyler and the baby? A, proteins from beans and rice. B, minerals such as magnesium and selenium from grains. C, folate from dark green leafy vegetables. Or D, B12 from fortified foods or supplements. Okay, what would you suggest for a vegan person and their baby? Protein from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, B12 from fortified foods or supplements. Okay, take a look at this. A bunch of you have voted, figuring out the voting mechanism. Maybe you're not in your car driving somewhere, which is helpful. not multitasking or ultratasking too much as we're chatting. Okay, Jill, I think we're good here. Great. The correct response is D, B12 from fortified foods and supplements. So vegan diets, as you know, have no animal products, which are the only dietary source of vitamin B12. To avoid that B12 deficiency, vegan parents and those who consume very little animal protein may need to take steps to make sure they receive enough vitamin B12, either from foods enriched with B12 or by taking a regular B12 supplement. Okay, great. Next question. What is the primary reason for providing human milk to premature infants? Is it A, to provide bonding between the breastfeeding, chest-feeding parent and baby? B, assure continued breastfeeding, chest feeding after discharge? C, significantly decrease the risk of necrotizing enterocolitis? Or D, to improve neurological outcomes? So what is the primary reason to provide human milk to premature infants? Is it bonding, to assure continued success after discharge? Is it to decrease NEC and EC? Or is it to improve those neurological outcomes? So most of you are getting this one correct, which is great. Okay, good. I think we can close it now. So yes, we didn't fool you early with this one. The correct response is C, significantly decrease the risk of necrotizing enterocolitis. So most of you got this one correct. And while the other ones are potential benefits, the question asks for the primary. Okay. Now we're going to take a look at the potential risk of skin-to-skin care in newborn infants, which it includes which one of these things? Is it A, respiratory instability, B, sudden unexpected postnatal collapse, known as SUPC, C, hypothermia, or D, sudden unexpected infant death, SUID? Okay, so what is the potential risk of skin-to-skin care in newborn infants? Respiratory instability, SUPC, hypothermia, or SUID? Everyone's doing really well on all of these questions. I'm hoping it's giving you a little bit of confidence and or just giving you a little nudge as to where you still need to study in the next few weeks. Some people aren't quite sure on this one. It's okay, come on, you can vote. I don't know who voted for what, so no call out here. Okay, great. Go ahead. The correct response is B, SUPC, sudden unexpected postnatal collapse. And so there are criteria that both hospital staff, how they can educate parents to ensure that SUPC does not occur during skin-to-skin. And so there is a checklist. Susan Ludington-Ho was one of the lead authors, and so do take a look and see. If you're not familiar with SUPC, it's definitely something which I highly recommend that you do learn a bit more about. And it's not respiratory instability, because skin-to-skin does the opposite of that, right? So it provides more respiratory stability, and it's not hypothermia, because the breast actually and the chest actually help to stabilize the baby's temperature. Hypothermia is low temperature. And indeed, several of you picked sudden unexpected infant death, but SUPC is what is actually mentioned in the research. Okay, take a look at this picture. So we'll let it sit up for a few extra seconds. So take a look at the hand technique the parent is using. It's useful for all infants except whom? Premature infants, Down syndrome infants, neurological impairment, or infants with a type 3 ankyloglossia. So what is this hand technique useful for? It's useful for all infants except premature infants, Down syndrome infants, neurological impairment, and type 3 ankyloglossia. Okay, great. Yeah, people know their stuff here, which is great on this question. Remember that the question is this hand technique is useful for all infants except. So that's known as a negative stem. And so instead of saying what is the most likely, this one says which one isn't, right? It's helpful for everything except for which one. So it's helpful for 3, but not with the 4th. Okay, Jill. I think everybody's a little shy on this one. The correct response is D. Most of you got it right. So the answer is ankyloglossia. So it is not necessarily helpful for the ankyloglossia. It is helpful for premature infants, for infants with Down syndrome, with the hypotonia, neurological impairment. This hand technique can be helpful for all 3, but not type 3 ankyloglossia. Okay, great. Last question. The WHO guidelines, the World Health Organization guidelines for preparing powdered infant formula recommend A, boil the bottles and teats for 20 minutes, a rolling boil. B, boil the water used for mixing for 20 minutes, also a rolling boil. C, mix the measured amount of powdered formula and hot water, which is 70 degrees centigrade or 158 degrees Fahrenheit. Or D, store prepared bottles in refrigeration for up to 72 hours. Okay, so this is the reconstitution of powdered infant formula. What is the recommendation? To boil the bottles and teats for 20 minutes, to boil the water for 20 minutes, to mix the formula and the hot water together, or to store prepared bottles in refrigeration for 72 hours. Okay, good. Last question. And then Sekeita's got so much valuable information coming your way. I can't even. Yep, keep going. There's a few sophisticated distractors in here, not just one, which is great. And the nice thing is that you can find the World Health Organization guidelines in a lot of different places, which is super helpful. Okay, great, Jill. I think that's it. So yes, most of you got it correct, which is to mix the measured amount of powdered formula and hot water together. And that number there, you do want to see that it gets up to that temperature. That's something which is important. You know, boiling the water and boiling the bottles and teats for 20 minutes as well as the water for 20 minutes. Both of those are sophisticated distractors because it's not for 20 minutes. It's only just to boil it, and you bring both of them up to that boil, and then that's usually good. But the water, of course, you need to get it up to the 70 degrees centigrade. And prepared bottles of commercial milk formula last in the fridge only 24 hours. So that's the reason why D is incorrect. Okay, good. So, Sekeita, how would you like to take it away and talk about survival, exam survival guide?
I'm going to fly away. I have 15 minutes to get through something that's, so I'm just going to say for just a quick minute that all of the questions that Angela just went through, some of you in this space might be feeling a little anxious. So I'm going to ask you to take a cleansing breath, okay? Because this information that I'm about to go through, some of it is very important, and you'll need to know this information in order to be successful on your exam. Okay, so take that cleansing breath, and then I'm gonna move on. I'm gonna move on to what does it look like. Okay, so really, you know, when you think about taking this exam, you want to take a pause, give yourself a hand, because preparing for this exam is not just easy. It's just not. It is challenging when you're trying to figure out what's fair game on the exam. What does an exam look like? And I believe that can be for any exam, for anyone who has, for example, test anxiety in general, right? But just remember your passion. And when you get ready to go to the exam on the exam day, you want to remember your passion that morning of. You want to remember all the hours you dedicated, and then you want to remember, okay, I just got to get over this and I am going to endure. But in order to do that, there are some things you need to know in order to arrive at exam day. So I'm going to move on and talk about, these last few days of staying connected to your passion. Right now, this is called 30 days. Some people may be taking the exam in the next 30 or 40 or so days. Really and truly, if you need to prepare, you want to prepare and focus on the things that you have areas for improvement, or that you have some challenges in. And by doing the test questions, a lot of times you'll start to understand where your challenges lie. If you are strong in one particular area and you know that, you know what? You can breathe a little bit and move on, but you do want to focus on the areas where you really need to, like, study a little bit more. All right. All right. I talked about breathing deeply. The reason why I said breathe deeply, and this is not just a calming technique, because it is a calming technique, but the reason why it's so important to breathe deeply, especially when you're going to be taking an exam, is because when we are stressed, some of us take very shallow breaths. When we take very shallow breaths, we are not getting as much oxygen to our brains. When we're not getting as much oxygen to our brains, sometimes it's very hard to think as clearly. So taking those deep breaths is, yes, calming, but at the same time, there's also some physiology to it that you want to make sure you're not breath holding. Some of us breath hold and feel like, okay, I'm going to pass out, those sorts of things. So you want to remember that before you take the exam. It is so important that you go to the website. Some of us will be taking the exam, and I said us, I won't be taking the exam again, I'm sorry. Some of you will be taking the exam on site, in person, at a testing facility. Make sure you know what all is entailed in taking at a testing facility. Make sure you know, for example, if masks are still involved. Make sure you know what time you need to check in for the day before that exam begins. Make sure you have done a test drive. One of the things that I always say is, if I know my test exam is at 8 o'clock, particularly when I was testing, and if there was a new testing site, I would do a dry run drive to see what's the traffic pattern like. Like, you really want to take into account. You don't want to leave if the GPS says it takes 30 minutes. You don't want to rely on that. You really want to rely on leaving a good amount of time. Now, just as if you're taking a test at a testing place, if you're taking it at a proctor, if you're doing proctoring at home, you really want to make sure that you have a computer that you can test on. I'm going to tell you right now, you cannot test on a tablet. You have to make sure you have stable internet connectivity. You also need to know that there are 3 security measures that's going to happen. They really want, and they do a personal check of you. They want a camera where you will be able to have to check the environment of your workplace. They want you to be able to check a personal check of your body, yourself, and this includes your ankles, turning your pockets inside out, raising your sleeves, your shirts where you can see your wrist. If you're wearing glasses, you'll have to remove them. These are all part of those security checks. You'll have to remove jewelry. You'll have to have your hair pulled back to kind of show your ears. So if you are taking this as a remote proctoring exam, I am not going to go over every single thing in detail. What I'm going to say is there is a website that you can go to, and you can go over the checklist to make sure that you are ready for that day, because it's really, some people, let me say it like this, real life have been booted out of the exam, or disqualified, if you will, is the correct word, because they did not take the time to understand what was expected from them, from the example of, yes, there are certain still parameters. that you have to have, all right? Know that there are a lot of break times. You want to know that if there is break time, you still have to check in with the proctor if you're going to remove yourself from the view of the camera. And you also want to know the terms for automatic termination. So it's important that you know that for yourself. And so that's why I said go to that website. There are computer system requirements, which is another, and this is that website that I said to go to so that you are familiar with what you need. The biggest thing you want to know is, what do you have to do if you start to have technical difficulties? The reason is because this is a time test. The only people that are allotted extra test taking time are those that have certain needs, and they have already cleared it, and it's already written into that they are allotted extra time for whatever those reasons are. So you want to make sure that you know what to do in case you have technical challenges. But just to let you know, for example, and I'm just going to give you a couple examples, dual monitors configurations are not permitted. Right now I have a dual monitor. I have a second monitor. I'm behind this monitor that I'm talking on, right? Those are not permitted. If you have for example, a Microsoft Surface Pro, and this was a big aha for me, that is considered a tablet for the purposes of the live proctoring exam, and it is not to be used. You can't use it. And so with that being said, you do want to make sure that you know what your computer requirements are. Remember I talked about they're going to do this security check? Well, what does that entail? That means you need a web camera that can move. So you need a movable web camera that can check all of the things that they need to check for the security checks, all right? So that's the level of detail that I'm talking about, that it really behooves you to make sure that you know what to do and what's expected if you're doing live proctoring. Going back to, if you are taking the exam in person, you do have to make sure you have 2 IDs that actually match your name with IBLCE. Your IDs have to physically match your name with IBLCE, all right? And it's important to check in at least 30 minutes ahead of time of the scheduled exam, and that's to allow, because there's also security measures when you take it in person. So the other thing is just be sure to check to see if masks are still required in your testing area. Now, for the purposes of strategies and test taking strategies and how you prepare for it, I want you to try to think about other exams, important exams that you've taken, and what worked for you. What worked when you were successful and what didn't work? So when you were unsuccessful, what was the difference? And this is a reflective exercise, and it's only for you to write down your thoughts in order for this to make the most meaning of these next 30 days. So if you feel like you got a good handle on everything and your nerves, you want to stick with that. But if you're really nervous right now and you're feeling a little overwhelmed because of the amount of information we've gone over, or that practice exam that we just gone over, it's very important that you take a minute and do some self-reflection of when were you most successful on certain exams and when you didn't do so well, and come up with a different strategy or a new strategy other than what you've been working on. So I said that and because I want to leave you with this quote, and this is a favorite quote of mine because I read it when I actually read it from a book when I was studying for my nurse practitioner certification exam. But this quote says, many students cannot pass their exam because they fail to sacrifice the minimum capital of time and money. So what am I saying? Yes, your time is capital. How much time you put into studying, not cramming, but actual true, intentional, meaningful study is so important. And sometimes that means saying, hey, I'm not doing so well in this area. I may need to purchase something that's going to help me, or I may need to borrow something that's going to help me, whatever the case may be, right? But keep that in mind, because the capital of time and the capital of money, this exam, is that important for you. If you are sitting to take this exam and you already paid your money to do it, I know that it's important. So you want to make sure that a couple other things that I talked about as far as security in your spaces, you have to be alone. No pets or people. I'm going to say this as it relates to cats, for example. Like, cats are so quiet, sometimes you don't know where they are, and you want to make sure that all of a sudden your cat doesn't pop up on the scene behind the camera, because that is disqualification. So you have to plan to be alone. No people can enter the room. If they do, that's an automatic disqualification. You want to also consider in the internet, you want to consider good lighting, and you want to suggest that everybody, is there anybody there that's streaming on social media, that's using the internet, that they're not using the internet. And also consider having a hardwire your Ethernet cable, so that you make sure that you decrease the risk of having internet connectivity issues. And also ensure that you are quiet. So that means talking to your family, telling them how important this exam is. That means being in a spot where you are totally alone and unbothered. All right, now the day before the exam, it's so important that you're kind of like trending down in the chill mode. You want to try to improve your confidence. You want to try to put a smile on your face. Some of that includes doing things like favorite songs that make you feel inspired or energized, or podcasts, or writing personal affirmations to yourself. Even you can start to do that now. And when I say write personal affirmations, some of the things that I have done when I'm taking an exam, and this is true, I put sticky notes all over places in areas where I was having the strongest challenges. The family might walk in a bathroom and have a whole list of sticky notes about this certain medication that I wanted to focus on. It's on the mirror. So think about things that you can do to improve, your study time. But the night before, you do want to focus on writing yourself personal affirmations. Then you arrive at the test day. The day of the test, I'm going to say to you, don't try to eat something that you've never eaten before. A lot of times people feel like this is a special test day, I'm going to treat myself. Eat something that you know. If you can go to the next slide, please, that'd be great. Eat something that you know is going to mesh before, next slide, please, mesh with your system, right? You also want to make sure you wear comfortable clothing. And at this point, it's the day of the exam. At this point, trust your preparation and do the best. If you start to look over and try to cram and all those things, you're starting to increase your anxiety level. Just arrive. The reason why we do these and the reason why we did the 90-day is so that you arrive on that day that you are ready, that there's no more preparation needed, that you are ready to take this test. All right, the test format is 175 total questions. There's 2 parts. Multiple choices will be the answers. And so part of the test will be images and part of the test will be just straight questions. But along with the images, you will have questions. And again, I already talked about the 4 hours. Each question has only 1 correct answer, so there is no penalty for the wrong answer. But it is to your advantage to answer all of the questions. When you answer the question, if you're not sure about that question, flag it, and if you have time, you can go back to it. But you have to answer the question. It is a benefit to yourself. All right, exam strategies. Make sure you read slowly. We have gotten to a place in society where we like to skim things, and sometimes we skip over words. You want to read every single word, and you want to think about what would be the first thing you would do, because sometimes, like Angela talked about, there are these sophisticated distractors. Eliminate the obvious wrong answers, and that way you increase your odds of getting the answer correct. You want to watch out for negative STEM questions. And remember, this is an international exam. And so when I say that, for example, I mean that you are looking at this exam from example, what does the World Health Organization say in relation to, for example, HIV and breastfeeding versus what does people in the US or the governing bodies in the US, what are they promoting? You really want to go with the World Health Organization. So you think about this as an international exam. If your mind goes blank, all you have to do is guess, breathe, and go on, but flag it. Work at a comfortable place. I've said some of this already. Just make your choice, move on, and review if time allows. I tend to talk over first impressions. I do want to impart this. Your first answer is usually the correct answer. Your first thought is usually the correct answer. You really do want to resist the urge to second guess yourself. And if you do, make sure that you know that this is the correct answer, right? But usually your first answer is usually correct. Don't read more into the situation. You know, they're not trying to trick you. The question stands as it is. Answer the question based on only the information given. A lot of times in clinical spaces, we'll say, but they didn't give us this, or they didn't give us this information, or this information is missing. No, there's no information missing. Answer the question based on the information that you've been given. All right, I've already talked about immediate termination or dismissal, but I do want to, it's bolded. You go into that check site, checklist, you will understand a little bit more about what immediate termination or dismissal. I do want to say this though, because this is something that has happened to a few students. Leaving the view of the web camera without acknowledgement from the proctor, including during your scheduled break, will result in an immediate dismissal from your exam. There's other reasons that you can be dismissed, but I do want you to make sure that you understand what's at stake. All right, once you get to the end of the test, it's a strange feeling to be like, oh, I'm done. And some people are like not ready to submit. Some people are like hesitant. Some people are like, so before you submit, if you do have time, if you have flagged your questions, remember that you have flagged questions, and if you have time, go back and review them. If you don't have time, submit your exam. Know that you're done. Know that it always seems impossible until it is done. But when it is done, it is a strange feeling. You're going to be waiting for these results. Once you take the exam for the first few days, it's normal to have some constant ruminations. Thinking about that, that's going to eventually fade away. What you don't want to do is obsessively check the IBLCE website, because sometimes it takes a while for the test results to come out. Remind yourself that you did the best, but the most important thing that you can do is prepare for your next stages. You want to stay connected to your professional community. You want to keep learning. You want to be like, okay, I'm passing this exam, next steps. What's the next step? And you want to kind of harness that energy to figure out, you know, once you get the exam results, what are you about to do, and how are you going to continue to professionally develop in your skills, develop in your knowledge, and develop in your professional commitment to families. And remember your why always. There's a reason why you sat here today with us for these last 2 hours. So just remember that. And I wish you much success on your exam and your preparation for your exam. Angela? I can't hear you.
Yeah, I'm muted. That's why. Thanks, Sekeita. Glad, lots of kudos in the chat here about all the information that we've shared. Hopefully it was helpful indeed. We tend to go on because we want to make sure that you've got the, you know, what you need, you know, in order to pass the exam. You know, someone is asking about the exam, what's a typical score, and actually IBLCE changes it from year to year. To the question about the new scaled system of scoring as opposed to the previous system of scoring, of providing with the raw score. Again, this is something that IBLCE has never done. And so we're all going to be waiting to see and to hear what, you know, what is happening. So yes, the recording is available to the person who just said, I know you weren't screaming, but yes, the recording will be available. either on our website or on YouTube within about 72 hours. And so, know that you've got this. Study the things that you feel that you are not doing as well in, that you haven't studied before. And, do take a breath, like the night before the exam, another thing. Did you say this, Sekeita? The night before the exam, stop studying, right? At least the night before, because, either you've got it or you don't. And know that it is, something which is challenging, and a majority of people, a strong majority of people pass this test. And so know that, kind of keep that in the back of your mind as well. As always, if you have questions about like some of the proctoring stuff, indeed, go to the IBLCE website, take a look at their FAQs. They should be up to date. And the IBCLC Commission's website, just, take a look at that and make sure that you've got everything that you need. So what else, Sekeita? You're looking away at the different comments and everything else.
Yeah, I was just trying to catch up on some of the comments. I don't really see, for some reason, my questions, like some of the questions that you were saying you could see, I am not seeing them. So I'm trying to figure out, did I click something? Like, what happened? So
sometimes
yeah, that's
when you organize it. Yeah, sometimes when you organize it, it kind of goes a little sideways. So
it says, I want to go back though to this one question. Can you give us some tips to study imaging parts in the exam? One of the things that you want to do when you're looking at an image is you look at the image first. You can look at it, you can divide it sometimes into quadrants, but I would kind of like say, read the question. So you look at the image, you read the question, and then you look back at the image, right? If you have a hard time and you're like, what are they asking for still? And you can't, and the reason why, for example, some of the pictures are taken in clinical practice. It's not like people are posing for these pictures, right? So you can't get a perfect picture in our practice. A lot of the pictures are from lactation consultants. They happen to snap these pictures, and they're getting these pictures at the time and point of care. The lighting might not be, good, but it might be a good picture for whatever it is that they're asking. And so I do want you to think about it like that. You look at the image, you read the question, and then if you're still like, what? Just you can divide it into quadrants to kind of figure out, So that would be what I would say about looking at the images. Angela, do you have any, any advice to impart about that?
Yeah, no, that makes perfect sense. And also remember that we have a blog post about it. But something that I can tell you is that when IBLCE is developing the exam, each question is reviewed by multiple people, meaning multiple clinicians from around the world. And so know that they look at each individual item and question and stem separately in order to say, is everything in here that people need to see in order to answer the question? And so, take that breath, pause for just a minute, and go ahead and answer the question. Someone just asked how many questions are photo? Half of the exam are photo questions. And so just so you're aware, and it's not just going to be some random photo, it's actually going to be a clinical photo. So if they're talking about a parent back to work, you're not going to see a parent who's just like pumping, right? The picture is actually going to provide you with the information and cues and clues that you need in order to answer that question, not just some random photo. So, and yeah, go ahead.
That was the only question that I can see this flagged. I don't know what's wrong with my question panel right now, but
Julie pinged you in our chat. So if you want to practice it real quick, but someone asked, is the exam different from year to year? It is. They come up with new questions every year. And every exam administration. So it's offered twice a year. And so they do come up with new questions. They've got a committee that comes together and that develops them. And the thing, to somebody who was asking about the scoring and everything else, we have a blog post about scoring, how IBLCE scores the exam, which may be really helpful if you want to kind of geek out. So we do have a bunch of blog posts about these different things, based on, we have a staff member who actually was on the IBLCE board and also who was on their exam development committee. So that's the information that we have. We're not telling you anything confidential because no one knows what's going to be on the exam from year to year. But in general, yes, there are new questions every single time. Julie just popped in 75 photo questions as opposed to half of the photo questions. So thanks, Julie. Appreciate that. See, takes teamwork to make the dream work, right? Okay, great. Well, I think this has been fun. What do you think, Sekeita?
Absolutely, very engaged group. I'm just excited that, you know, for the folks that did join us and spend time, that they are engaged with the questions and serious about this next 30 days, and just, you know, wish you all the best.
Absolutely. And if you do need anything, please let us know. We have over almost 700 questions in our QBank in our exam database, and we'll be launching new add-on questions, new questions based on the detailed content outline. So like if you're struggling in one area, like, you know, anatomy and physiology, or I'm sorry, physiology and endocrinology, then you can buy a little add-on package of just questions in that little detailed content outline area. So we're adding questions every day. So take a look at it and see. It's called LER QBank. So great to have everybody here today. Yes, indeed, you may see case study questions. We have a few of those in QBank as well. So that way you can practice. So thank you everyone for joining us today. I know when I said this is fun, we really do appreciate the engagement. And we know that, you know, there's a lot of things and thoughts and feelings about this exam. And so, you know, good luck to all of you.